Okay. All right, we have 1 minute. So, Riz, are you introducing the presenters and the discussants?
Sure, I can do that if you would like.
Sure.
Okay. To those of you that don't know me, my name is Riz Aslam. I'm down here in New Orleans at Tulane University. We're joined tonight by Alice Lin at Kaiser Permanente in LA. Dr. Andrew McWhorter, a colleague and friend here locally in the Louisiana area, is a advanced laryngologist, treats a lot of laryngeal cancer. So I thought it would be fitting if we had him on our panel tonight as well. He is at LSU and has the Our Lady of Lake Voice Center. We're also joined by our discussants, Dr. Laureano Garaldez at the University of Puerto Rico. He has the coolest background. I'm assuming that's a background, you're not still in the office. But Julie Goddard, who's at the University of Colorado, is kind enough to join us. She trained at the University of Cincinnati, so a fellow Cincinnati alumnus. Dr. Kendra Harris is our radiation oncologist at Tulane. She is on a call with the dean at the moment, but is going to chime in shortly. Dr. Marite Tang from Mount Sinai, head and neck surgeon, program director there. She is also going to be on the call as well as a discussant.
Okay, fantastic panel. All right, it's now 7:01. Welcome everybody. This is our Advanced Laryngeal Cancer Virtual Tumor Board today. It's 7 o'clock. It's a cold but sunny day here in New York City. It's 45 degrees. And we are very pleased to have you all. Looking forward to have a fantastic session. Riz, I understand you're presenting the first case.
Yep. So the first case of the night is a 63-year-old white male who presented to the ENT clinic as a referral from an outside laryngologist with a complaint of hoarseness. Initially complained to him with hoarseness, was scoped, found to have a lesion involving the vocal cord, and sent to us for further evaluation. The patient is currently a high-rise painting expert. He's one of the few individuals that paints the outside of high-rise buildings. So he noticed that it was taking him a lot more energy and he was getting short of breath while performing his day-to-day physical activities. He was accompanied by his business manager who manages the company. Otherwise, he's a relatively healthy male patient, no significant medical history, no significant past surgical history, no allergies, not taking any medications. Smokes 1.5 to 2 packs a day for the past 20 years, occasional, beer on the weekends, sometimes on the weekday. Review of systems, hoarseness, otherwise negative, no significant weight loss, no atalgia, no referred pain of any sorts.
Okay, and I assume that you have a picture of the laryngoscopy?
Yeah. So unfortunately, I don't have a dynamic video of his laryngeal exam, but you can see the left side of the screen. The patient, you can see a little bit of an airway on the left side, and you can see the similar type picture on the right.
Okay, so let's ask the panel. Alice, what is your practice in LA? Do you routinely video scope these folks and do a video from them? Do you do a strobe when a patient comes to you? You're mute.
At Kaiser Southern California, we don't routinely video. I mean, we do a flexible laryngoscopy. We don't routinely video these patients.
Okay. What about the strobe?
We don't strobe routinely.
Yeah. All right. So let's see. Laureano, what would you do in Puerto Rico? What's your routine to approach these folks?
Well, I train in both head and neck cancer and laryngology. So I usually do a transtracheal puncture with 4% lidocaine. And I let the patient get numb, and then I go below the vocal folds just to see the extent in the office, and I videotape it. Just because it's a practice that I use a lot with T1 and T2 carcinomas that are going to undergo laser surgery. I just want to know the extent of what it is. So I almost do it in every laryngeal cancer patient that I see.
Sure.
in my
And then, so just for the audience, for this guy who has kind of a iffy airway, would you still inject him in the office? Are you comfortable, or you like, nah, this is a little bit iffy?
I mean, if he has no stridor, I inject him in the office.
Okay, great.
I've never, well, if he has stridor, I don't, but if they don't have stridor, I do. In general, yeah.
Great. Okay. Riz, you want to continue? So what next? Oh, good question. Okay, let's open to the panel. Let's see who I didn't ask. Is Dr. Goddard? Julie, are you on?
Yes, I'm here.
Hi, how are you?
I'm good,
Thanks for joining us.
Yeah,
All right, so how do you approach these patients? What's your practice?
well, I think you mentioned, very astutely, his airway does not look great. But it seems like he's kind of tolerating that fairly well. So I think it would depend on how he clinically is doing in terms of what order we try to go in terms of, should we try to get some imaging? This looks fairly malignant. But I think probably first on my list would be to, get him to the operating room fairly soon. And it does look like he's an airway that we could obtain with a tube, and maybe even with our biopsies, try to debulk that and hopefully avoid a trach up front. But certainly I would discuss kind of all airway management issues and options that could come up with the patient before going in, and make sure we communicate very clearly with anesthesia, kind of all of those pieces.
Okay, great. That's all good points. And Andrew, are you on? Oh yeah, I see. You're mute. Okay, Marita, are you okay? Can you hear me? Okay, Andrew.
I can hear you now. I couldn't hear for basically the entire presentation.
Okay, all right. So let's ask Andrew. What's your approach in with these guys?
I think it's going to be the clinical assessment in terms of how does he look. Is he comfortable breathing? Is he having any stridor? Is he not? Getting a good examination, trying to get a little bit closer, seeing what the extent of that tumor is with that posterior component. Does he have full cricoretinoid motion on that side? Trying to get a better assessment of what's the functional larynx, how's he protecting his airway? Just so we know, obviously we need some tissue to see what's going on, but make sure we want to manage that airway appropriately. Like you mentioned, go into the operating room to get that tissue and seeing the extent of the tumor, really mapping out what are we dealing with here? What's that mobility on that left side? What does that look like?
Exactly. So thank you for all of you. The point here is, guys, you're the captain of the ship. You're basically driving the care here because you're the one that has all the information. Okay, Riz. So everybody seems like OR.
Yeah, so the patient was, obviously with his work, doc, I don't want to trach, look, you have an impending airway problem here. You probably should consider, this is a risk that you're going to end up with a tracheotomy. So of course he comes, shows up a little bit earlier than his scheduled direct laryngoscopy in the emergency department with stridor. We take him to the operating room, do a controlled establishment of his airway, tracheotomy, direct laryngoscopy, and biopsy.
So did you intubate or you just went to awake trach?
We just awake trached him.
Okay.
The tumor looked pretty significant on fiber optic flexible laryngoscopy, and he was a skinny neck, so we went ahead and did an awake trach.
Sure.
So this was his CT scan immediately post-op because he was admitted to the hospital, obviously. So we just got the CT scan immediately post-op.
Okay. We don't have our radiology colleagues today, so sorry about that. Riz, do you want to go over the CT yourself and then point out the points that are important to you, and then we ask the panel?
Yeah. So I think for the fellows, I think the obvious thing here is you have some air here in the neck, right? So a patient has a fresh tracheotomy. So immediately look for any concerns if there any other injury that may have caused that. But, it's all from the tracheotomy. Patient has a significant amount of coughing history, et cetera. So he just coughed and created some sub-Q emphysema there. But on the CT scan, there was nothing really significant in terms of the cartilage being invaded. The radiologist commented that there was a tumor extending above the glottis and a little bit into the subglottic area. Not transglottic, but actually on the laryngeal examination. And I apologize that I don't have the entire video to go over this with you. But otherwise, it looked like there may be a small node here. And really, that was the extent of the CT examination. It wasn't really
Okay.
anything that demonstrated any concerns for advanced laryngeal cancer.
So
one of the
let's
things I
ask-
do want to take a step back and describe is when initially we saw the patient in the clinic, there was some question about mobility. Maybe there was a little bit of mobility, but with the tumor so bulky, it's very difficult to assess if there's any motion of the vocal cord itself. So, it was hypermobile, pushing on immobility of the vocal cord. So just a little piece of information to add to that on the dynamic examination.
Riz, on the direct
Okay.
laryngoscopy, can you comment on which areas of the larynx were involved by the cancer from a staging perspective?
Yeah, so the tumor looked like it was an exophytic tumor. It didn't involve the ventricle, didn't involve the subglottis, but it was fairly exophytic and bulky in nature and kind of was ball valving through the larynx itself. It extended from the arytenoid all the way anteriorly to the anterior commissure.
And across the entire glottis, sort of like transglottic?
It looked like that, yeah.
Okay.
Well, I mean, the definition of the transglottic is has to basically pass the glottis. But if it's only involving the glottis, you say like 5 millimeter above and below the true edges, it's still glottis. So this seems to me like a glottis. It's a big glottic and very exophytic.
That was our working diagnosis.
Yeah, I would be a little bit more charitable and say it's still this is glottic. Okay.
The only thing that jumps out is if you go back, Riz, and you look at your sagittal section here.
Yeah.
When you look at your cricoid, there's a lot of thickness of that cartilage. It may be the slice you connected, but it certainly raises this question of, is there some submucosal extension of that tumor lower anteriorly? It's hard to say on the film, but it's certainly concerning.
So the question that always comes up at tumor boards with non-surgeons is everybody look at the CT and they try to figure out where is the cancer and how big it is. And we all know that really imaging is not helpful. So I was just going to ask the panel, how much do you rely on CT? And let's ask with Marita, because we missed it. So in general, for glottic cancer, how much do you rely on imaging?
Not much is the bottom line. I think it's really hard to tell, especially with secretions and with something like this, which I think looked like it was in areas kind of pedunculated. You can't really tell, especially on CT only. I think sometimes if you're really trying to make a decision about whether something is approachable through endoscopic resection, an MRI could be helpful for the glottis.
Great. Anybody would, so that's exactly same as Marita. I really don't rely much for a T1, T2 or glottic. It's not that great. Anybody have any comments regarding imaging for glottic cancer? Loriana, I see.
I would only consider it if you have suspicion that it's not, that it's beyond the glottis and it's invading into the cartilage. So yeah,
sure.
Outside of T1, T2 a cancer, if you're thinking about endoscopic resection and you have doubt whether that's extending deeply into the paraglottic space and against the cartilage, I would also consider it. Just because those patients don't do well with an endoscopic resection, even if it doesn't look like the cartilage is invaded through and through.
I will comment, just to follow up on Marita's comments, that for glottic cancers, paraglottic space involvement is a criteria for T3. And sometimes it can be very difficult to tell, like that middle image there, you could probably convince yourself the paraglottic fat might be invaded, but it's always hard to tell in the absence of a good clinical examination for fixation. I think they're very reliant then on your imaging to really tell if there's paraglottic space involvement, and an MRI can be very good at for that because it differentiates between the paraglottic fat very nicely. But that's if you have no other good reason to consider it being a T3 from a imaging standpoint, like a case like this where you don't have good functional data.
Okay, very good, Riz.
Just a side note for the fellows, I always like to look at the sagittal section, especially to look at the preepiglottic space and assess the fat. So if you see tumor infiltration here, that's an important prognostic indicator and also for surgical indications as well.
Great.
So no surprise, poorly differentiated squamous cell carcinoma on the biopsy. Discussed options with the patient. At this point, given that he had that lymph node that was suspicious, I wanted to see what you guys thought about the stage, here.
Good question. How much do you rely for this is glottic? Let's ask Alice. Alice, how would you stage these folks? Because sometimes, some of our colleagues insist on everything has to be FNA. If there is a node, then therefore there is an N1. but we all know that that's really low. So what's your routine? You're mute.
If this is truly a T2 with normal vocal cord function, then I tend to give them the benefit of the doubt, but I leave it up to whoever. If it's me treating the patient, then I usually follow the notes. If it's the radiation oncologist treating the patient, then I let them decide what they want to do with the next staging.
Mm-hmm. Okay, I'm very reluctant to biopsy a lot of these kind of borderline looking nodes, but
Yeah.
obviously if it's a big tumor, it's transglottic, then there's a different story. Marita,
Yeah.
what would you do for neck?
Sorry, I just got a message that I was looking at. I missed the discussion. I'm sorry.
That's okay. We were just thinking about how would you assess the neck, and when you have the CT, that's kind of like an iffy looking node, and you say, do you think it's real or not?
Yeah, I agree with you that usually that question comes up more with the non-surgeons, and they want every node sampled. If it's just a morphologically relatively normal appearing node, I don't get too excited. But definitely we always have to have this discussion with the multidisciplinary group. So sometimes we do end up sampling a couple of them almost to prove that they're negative. Glottic cancers, I especially don't worry about it much.
Julie, what would you do in Colorado?
Yeah, I think we have the same discussion that everyone is sort of mentioning, and I think my colleagues are much more concerned about nodes, and that's when we kind of started talking about, okay, is it truly supraglottic and infraglottic? What is really the risk of, especially if you're talking about bilateral or contralateral disease. So yeah, we definitely do some FNAs, hopefully to kind of get enough information to say this, we didn't find definite cancer here, so maybe we can consider that more negative. But yeah, it is a discussion that comes up frequently in terms of these nodes.
All right, so Riz, do you have any other pictures or information, or should we ask panel what would they recommend?
You're muted, Riz. Riz, you're still muted.
You're still muted.
Okay, sorry about that. So the patient wants to proceed with non-surgical intervention after discussing with him. So I think my question to you guys, or Baba can present, is what treatment would he get if it was non-surgical? He wants to continue to paint and work and do all the great stuff that he does. So
that's your curveball here, huh?
Yeah, because it's this glottic cancer. Maybe has a little mobility. Maybe it's immobile. He's got a node. How extensive of a non-surgical pathway is it going to be for him?
So basically, the question is here. Let's just keep it simple. Are we doing limited, laryngeal radiation only, or we are doing, chemo RT probably with neck and larynx? So let's ask Julie first. What would you tell a patient, and what would you recommend?
Well, yeah, I think if he's really wanting non-surgical management, then I think at my institution, he's going to be looking at radiation plus chemo, and he's getting neck radiation as well. So it's going to be, wider field, more extensive treatment for T2N1 or T2N2C. I can't tell where that lymph node is. Sorry. So I don't know if it's on the same side or both the other side, but nevertheless,
the same
I
side.
think that the node is going to up the ante in terms of his treatment and what's going to be offered to him, at least here.
Andrew?
Yeah, I think that in non-surgical management, you have to address these necks, right? Regardless if that node is there, based on that arytenoid involvement that's there. It's actually, when it's going posterior, I think the risk of nodal metastasis is a little bit higher. And so he's going to get, certainly radiation to the necks, and the role of chemo is going to be depending on what that PET shows, probably.
Do you get a PET before you recommend chemo RT?
In this guy with the posterior extent and this question of is this node or something, he would get a PET as part of his treatment planning for radiation.
Sure.
So get his PET in treatment position, and we'd use that information regarding, the role of chemo at that point.
Okay. Alice, what would you do?
You know, at our institution, these patients come through a head and neck tumor board, and we evaluate them all together. So me, the surgeons, the radiation oncologist, the medical oncologist, we all look at the we do the laryngoscopy together. And if this patient was being treated non-surgically, they would do a PET scan to look at that lymph node, maybe do an FNA. So is the vocal cord mobile or immobile? Is my question.
The problem is so bulky, it's really hard to figure out.
Right.
Yeah.
So I think
The question becomes
yeah.
is to upstage him and
Yeah.
treat him, or not. So
Yeah.
you guys all raised the important points in the similar discussions that we had. So he elected for radiation therapy, chemotherapy. He met with our radiation oncologist, medical oncologist. He did have a PET. Andy brought that up. We did PET him, and our radiation oncologist like to use PET CT for planning. So he went on. Went through his treatment. He did okay. I guess my question is for the team is, when do you scope these patients again after they complete their radiation? Do you scope them during radiation to see if they're responding? Do you scope them 4 to 5 weeks out, 6 weeks out? When do you scope them?
So we have 1 or 2 minutes to go. Let's ask Loriana. Loriana, what's your routine when you're with your patient on treatment?
Well, I let them finish chemo radiation, and I see them the first week out after they're done with the treatment, just to see where they stand. And then I follow them every 6 to 8 weeks in my practice.
Yeah, I have a very similar practice as well. Marita, what would you guys do at Sinai? Would you see them during treatment or after treatment?
I definitely don't see them during treatment unless there's some airway issue. I also try not to scope them too soon afterwards, because it just seems so edematous that it's hard to make heads or tails, I feel like. It's probably not a bad idea. It sounds like many of you guys like to have a baseline exam, but I just feel like in the few weeks immediately after therapy, they change so much that I typically don't scope them for the first time until the 12-week mark.
Oh, wow. Okay, great. Julie?
Yeah, same. We will sometimes see them somewhere around 6 to 8 weeks out, but then the 12-week mark is most standard in terms of when they're getting a post-treatment scan and an exam. So sometimes it varies based on the patient's, geography and things like that.
Yeah. Okay.
I would say if they're having any symptoms or if something's happening, obviously scope them earlier. But.
Absolutely. So I guess there's most folks, as long as the patient's doing okay, we don't scope them during treatment, and maybe even I like to see them the first week after treatment. And sometimes I just scope them and document it, just because you see. But I completely agree with Marita that probably whatever we see, you don't do anything yet. Don't jump the gun right away. Yeah. Okay.
Babak, this patient, so he went in, he came in a month later, and no surprise, he had a positive lymph node that was palpable on the left side of his neck, also one on the right side of his neck, and we did a flexible laryngoscopy, and he had a left vocal cord lesion. I took him to the operating room, performed a FNA, ultrasound-guided FNA while he was asleep, and multiple biopsies of his airway. Unfortunately, he had the left vocal cord well-differentiated squamous cell carcinoma, subglottic, poorly differentiated squamous cell carcinoma. There was some irritation above the trachea around the stoma that was negative for malignancy. So at this point, we had to make a decision, obviously, for salvage surgery.
So he basically blew through chemo RT. Not only didn't get better, it just got worse.
Yes.
Okay. Well, I guess we all know how this goes.
Yeah.
Okay, what did you decide? So, sorry, we're kind of running out of time for other presenters. So if you want to finish.
Yeah, I'll just present really quick. So he had these cystic neck masses. You can see cystic lymph nodes on the right side there. This is kind of what his larynx looked like. You can see his PET scan kind of lit up pretty significantly. We took him to the operating room. But the interesting thing is, after his direct laryngoscopy was performed, he had extension along the side wall. We took him to the operating room the day of surgery, and it looked like the tumor progressed. So after we removed the trach, you could see the tumor hanging through his trachea to above his trachea, where his trach site is. So this is a lateral picture here you can see. Again, here you can see the tumor. I mean, this is one of the most aggressive laryngeal tumors that I had to deal with. But anyway, long story short, this is the patient's larynx. They did en bloc resection of the necks. We call this the Florida laryngectomy if you live in New Orleans. But you can see here, the problem is the patient noted to have pharyngeal involvement all the way around circumferentially around the pharynx. So at this point, you now kind of went from a salvage laryngectomy to a pharyngectomy. And I guess I was going to ask the fellows or the team, sorry, what would you do at this point? So now you're in the operating room and now you have a circumferential pharyngeal defect. And the gray bar is supposed to end here, but it kind of gives away my answer if I show you what's underneath the gray bar.
Well, at this point, I usually call my partner saying, hey, I need help and I'm leaving town. Let's see. Julie, what's your practice in Colorado for circumferential? Okay, 1 minute. We gotta go really quick poll.
Yeah. So we would have, I use a lot of tubed ALT or tubed radioform to do the circumferential defect.
Marita?
Yeah, tubed ALT because I like the muscle.
Yeah, Andrew?
He would get a tubed ALT for a 365 pharyngeal defect.
Yeah, and it's amazing that the jejunum is completely fallen out of favor. Okay, go ahead.
Yep, so I actually, because I was in the operating room doing this case, I went ahead and elevated a supraclavicular flap, even though he had prior radiation, Dopplered it out, no problem at all. And what I do is I just turn this in. You can see the suture line above, suture line below, tube it over a salivary bypass tube. And this is a quick video, and then I'm done with this case presentation. So, and it's the same supple, flap that you would have with an ALT. It's going to be buried. I don't have to worry about monitoring it. I know intraoperatively, if I see bleeding from the distal aspect of the flap, I don't worry about it, at all. And I also exteriorize this portion of the flap so that I don't have to monitor it or Doppler it or anything. And if this skin starts to look dusky, then you have a problem.
Sure.
So you can see here, I'll drop the skin flap and I incorporate this directly into it. If the patient fistulizes, I know they're going to fistulized here laterally or inferiorly. But you can see here, this will be all incorporated into the skin. So all this flap here. And this also helps when you're doing salvage laryngectomies to put this in, just because they get that tight neck flexion. And but long story short, that's what we did. So it was T4A cancer. Unfortunately, the patient did not do well several months later. Not to any surprise, but some of the worst massive lymphadenopathy that I saw.
Exactly. All right. So unfortunately, we are it's a fantastic case, and really there are a lot to say about this case. And the only paper I mentioned to the folks is the Michigan paper on induction chemo as a key selection. And this is exactly the patient that's going to do worse, as Jeff mentioned in the chat box, that when a patient fails very quickly, they're not going to do well. All right. So let's start with the next presenter, and I'm going to move a little bit faster. I believe it's Andrew presenting the second case, correct?
That's fine with me.
All right.
Let me share my screen here. Can you guys see me?
Yeah.
All right, happy St. Patrick's Day. And thanks for letting me, as a laryngologist, be included. So I won't take a case on exactly like Riz's there. So 58-year-old female, 3 months history of right otalgia and throat pain, presented to the outside otolaryngologist. She said she'd been hoarse for 7 years. She had polyps, maybe papilloma removed. Patient underwent a direct microlaryngoscopy with biopsy of the right arytenoid. The final path was a well-differentiated invasive squamous cell carcinoma. The outside otolaryngologist got a CT of the neck and chest, which showed some asymmetry with no lymphadenopathy and a clear chest. So past medical history of hypertension, some arthritis type of things with her non-steroidals, 30-pack year, quit 7 months ago. And on physical exam, this is what she sounds like.
If I can get you to read that out loud, it says the rainbow.
The rainbow is a division of white light and truth.
Okay, and she has arytenoid mass, and the neck is benign. So 70-degree scope. This is what we're looking at in abduction, and adduction, and here's the video for you.
Good. Let's say E. Good. Deep breath. And a higher pitch E. Good. And a long, soft E. Good. Say heat, heat, heat.
Great
Okay.
video. Thank you. Okay, Laureano. What's
What do I
next?
do? What's the question?
What's next?
I get a CT scan would be the first thing to do with IV contrast, obviously,
Okay.
to see the extension of the arytenoid mass.
Yeah, I agree. Okay, in the interest of time, I think everybody would agree that this case, really, the imaging is important. Andrew, please guide us.
Yeah, so the CT scan was just some asymmetry. Unfortunately, I don't have those images because they came as a referral from an outside. You can see the mass here, obviously, the right arytenoid extending towards posterior commissure, and you've got the irregularity of bilateral vocal folds. So they had a radiation oncology evaluation in terms of evaluation, and recommended for radiation of larynx and necks, and hyperfractionated, and had a PET CT scan done with that.
Yeah. And did you have a biopsy, or did you biopsy, or she came in with a biopsy?
Presentation, they came with a well-differentiated squamous cell carcinoma.
Squamous cell carcinoma.
Would you have considered, and I'm sorry to interrupt, would you have considered reviewing that biopsy in your institution before?
Yeah, I think that's always a good idea, to look at outside path, certainly in that way, to make sure that there aren't, problems coming in terms of making a judgment. He clearly has a carcinoma, that right arytenoid, though.
Yeah.
Well.
Do you guys, let me ask the panel, anybody routinely sends non-oropharyngeal for P16 or HPV? Alice or Marita or Julie?
Not routinely, but I was thinking that too when you said that she had a history of a polyp before. I was expecting it to look different when you showed it to us. I thought maybe it was, especially because you said it was possible RRP. So, we don't routinely.
Sometimes if there's a question of some extension to the oropharynx or hypopharyngeal, there's recently been some studies showing that P16 might make a difference to their prognosis. I will sometimes send P16.
So at NYU, we have started routinely send all head and neck squamous cell carcinomas for P16, regardless of their subsite. And it will be surprising to see a number of these supraglottic cancers, especially if they're on the epiglottic side, they come back as a HPV positive. All right. But I agree, it's not in the NCCN guidelines yet.
Yeah. This lady was P16 negative.
Oh, okay, wow.
With that, with this questionable history of RRP, is it a useful point of, information potentially? But it certainly comes up. You can see the PET here. Isolated to the larynx. This is how the residents send me videos now, or images, when you're on call. So I borrowed their trick using my phone here to make it quick and easy for you. So maybe a little bit of lighting up in the at the glottis as well. So we have a T2 N0 M0 squamous cell carcinoma of the right arytenoid with these irregular true vocal folds. Oncology, radiation, and then they want to know what our thoughts are.
For the purpose of discussion, are you calling those vocal cords clear and scarred only from prior surgery, or are we saying that the cancer extends under the vocal cord? Because I think it's a critical part of the discussion.
I think that it's suspicious, but we don't have an answer at this point.
Okay.
Okay. This is a tough one. Let's see. Yeah. Alice, surgery all the way. What would you do?
Well, I think I would biopsy. If there's only a right arytenoid biopsy, I think I would biopsy other areas because it looks a little suspicious. I don't know. I would like to know that the pathology is just in the right arytenoid.
That's a great point. Julie.
Oh, yeah, I agree. My question has been what's going on with her glottis since we first saw the video there. So I think that has to happen before you can really move forward.
I agree. I think this is a fantastic point that's raised by both of you. And I think in these cases, there's nothing wrong with going back to the OR and do your own biopsies and do your own mapping and figure it out. I think it's very, very helpful in these cases. I completely agree with you. Loriano, any comments?
There's a question from the audience real quick about if you do biopsies, would you do them in the office like transnasal scope, or would you do a DL biopsy?
I do a DL biopsy probably, because you want to look at the extent. I mean, the high-pitched voice is not due to the mass in the arytenoid, it's due to the papillomatosis that she still has in the larynx, or at least the changes from previous surgery. But I do it in the OR because it will give you a clear idea of whether you can resect this or not endoscopically. So, you know, or you're gonna do something open and hemi. I mean, that would be the purpose of mapping, I guess.
Okay, I don't know if Kendra has joined us yet or not, but Kendra, if you are on, please comment as we go forward. Okay, Andrew.
I would just make one comment on that. I would say that if the ladies can do radiation, I don't think that it matters. They don't have to go to the operating room for what we're doing. But if we're considering conservation, I agree completely with everybody's thoughts that you need to have, you know, a good endoscopic evaluation to see. Ends up this lady had known a person with a total laryngectomy and who had had it after radiation, and she really didn't want to have radiation. And so she was taken to the operating room, and this is the glottis up front here. You know, it's definitely irregular, you know, looks squamous, not papillomatous. You can see the communication here off of the right arytenoid onto that true fold, and here it is now. So you've got this right arytenoid tumor that extends down onto the glottis and is encapsulating the anterior commissure and the left true vocal fold.
So that's all tumor?
That's all tumor.
Oh, okay. I guess now you all know how important it is to do these DLs when you're making decisions. Marita, what would you recommend?
Well, I thought from the very first endoscopic picture that I would have done almost anything to avoid operating on this person, just because there is so much field effect. You can't tell, even just not with the glottis notwithstanding, you can't tell where that arytenoid mass here in the operating room, you can tell a little bit better, but it's not easy to tell where it begins and ends. And because of how abnormal that glottis looked, I would be very hesitant to do surgery. It also, I mean, there are several laryngologists on the call, so including the presenter. So maybe you guys can comment on whether what you thought. Her voice sounds so entirely abnormal and so strained that it can't be just from the arytenoid mass. So there were so many clues from the very beginning that the tumor was much more than the most obvious part.
Yeah, great point. I agree.
But it did look papillomatous from a distance. So that's the importance of taking it back to the OR and biopsying it. Yeah,
absolutely, I agree. And you know, but it has an infiltrative sounding to the voice.
Yeah,
that
of course.
So is that scar maybe from having had a lot of papilloma surgeries and she's not a good historian, or is that tumor? I think that those are all things, you know, that makes this case not as straightforward.
Yeah, no, absolutely. Very fascinating case. Okay, so what did you decide?
Well, she refused radiation.
Oh boy.
So this is the endoscopic section. And you can see here that we've resected across the posterior commissure, the posterior aspect of the right false focal fold, and down onto the arytenoid. And we've resected the left true vocal fold, but not the right true vocal fold, and staged this. And you guys may ask me, you know, why did I do that? Trying to give her a good voice outcome. I feel like if you take that right true chord along with that right false chord at this point, we're going to have trouble. She's a T2 N0. We're going to come back to do her next based on this arytenoid disease. And so I'm going to see how we did on this first resection. And I'm going to plan on resecting whatever is left at the second turnaround, you know, at 4 to 6 weeks, depending upon how she's healing.
Oh, well, obviously very challenging case, fantastic case. And, you know, the point here is there are many ways to skin the cat. And all of us, we should do what we are comfortable, and no, and obviously Andrew is very experienced and is comfortable doing these staged procedures. And sometimes the patient will dictate you, and that's I completely understand. I think most of us, we would have gone to non-surgical, but hey, that's why we have these tumor boards, to see these different practices.
Well, I know it's controversial, and certainly all the fellowship directors and the fellows are kind of cringing. Who is this crazy laryngologist who is doing a TLM on this case? But this is the thing of practice. You sometimes are backed into these corners and have to make decisions, for the patient. And how do you handle some of these tougher situations? So I thought there was some benefit of this. So we resected this, and we hadn't, the margins that were positive at the areas that we did not resect, but otherwise were clear. She did not have lymphovascular perineural invasion. This is 1 week post-op, and you can see there's a big defect here in terms of this granulation tissue extending, up the petiole of the epiglottis, all across, with the false folds kind of fallen forward here. The cord itself has fallen forward in terms of the right cord. It's not disarticulated, but there's a raw surface. We've really tried to be expansive because, as Dr. Tang had said, knowing where this thing started and stopped, you needed to make sure that we didn't want to undersell this lady in terms of resection. Important things when we were considering surgery were, she was seen by speech pathology ahead of time. She was taught a supraglottic swallow, and you can see her breath hold here where she's getting good clottic closure, and you can see the cords with the healing left cord and the right cord. And she was able to, go home on an oral diet immediately after surgery, with this having practiced the supraglottic swallow ahead of time. And so this is 1 week post-op. But I think the speech involvement's important when we're thinking about getting in this posterior commissure and what we're going to do and how we're going to help rehabilitate her.
100%. Couldn't agree
Robert,
more.
can I make a quick question?
Yeah,
Comment
absolutely.
that were brought up on the chat box. I think a couple of things. This was brought up earlier in the discussion, whether they were a smoker or not. And then at what point do you consider like PFT evaluation if you're doing either basically partial laryngeal surgery for somebody who has likely underlying pulmonary disease is one question. And then the other was just neck management on this patient, unilateral versus a bilateral surgery.
I'll tell you that we don't get PFTs, but she could climb 2 flights of stairs, which I use as my rule of thumb. And there are people who we're in a multi-story building, we'll even take them out there and make them do it in some of these cases, just to see can they really do it in terms of doing that. And I'll tell you how we manage the necks in a second here, but I'm welcome, the rest of the group's comments on that.
Sure.
Andrew, can I ask you, do you do any augmentation procedures, and how do you time it when you do a bilateral resection? And what do you predict the voice outcome will be?
So, anterior disease that spreads across the anterior commissure is hard to predict in terms of what you're going to do. I definitely think we can get better voice outcomes with stage disease if it's superficial. Obviously, if this was an anterior commissure tumor that was going deep into the tissues, we're not going to stage that. This was superficial spread where it kind of skated across the top of the folds. You saw we were able to keep the muscle underneath and even the ligament for the most part. And so in terms of augmentation, I wait until healing further on down the line.
So after you've done all the resection, like all the resections finished.
Absolutely. This lady had a swallow study at 10 days. You can see with her supraglottic swallow, she's not penetrating or aspirating with this. At that post-op, first week exam, she's getting a FEES exam, practicing holding that breath, making sure, that she can get that closure. Here she is at 3 weeks post-op now.
Oh, looks good. It's amazing how much they heal with laser and TLM. Okay.
We've got persistent disease on this right cord, which you can see, but the left cord's looking good. You can see she's mobile. She's opening and closing at this point and protecting her airway. And so then back to the neck. With even though she's in 0, especially with posterior arytenoid disease, I feel like you've got to manage both sides of the neck with these people. If she's not going to have radiation in the field, I think this tumor spread across the anterior commissure. So while we're there, instead of doing ipsilateral neck, we did a bilateral neck on her.
Okay. All right. In the interest of time, because Alice has a case too, so tell us how this amazing case ends.
So here's 6 weeks. You can see the tumor isolated to this right cord. We're clear in the posterior commissure. We do a right true vocal fold resection here. Here she is 9 days post-op after that. She's really starting to heal. And here we are at 5 months. Here's that voice.
Go right ahead. Where it says the rainbow.
The rainbow is a division of white light into many beautiful colors. These take the shape
And here
of
she
a
is.
long round orange with its powerhouse above and its two ends appreciate.
It's like you have a little bit of a web posterior, but I assume that you
Yeah.
actually like that to have that.
Yeah. So yeah, she's got a little bit of scar from that, where she's resected that arytenoid in the posterior commissure. But she's protecting her airway well,
Yeah.
and she's healed well.
Excellent. Amazing book. So, well, I know when people, when they don't want radiation, whom to send them to. All right. Thank you.
Right.
We could talk just the entire hour about this case. But Alice, would you please start? This is a fantastic session. These are amazing cases. You're muted.
Sorry about that. Hold on. Let me do this one again. So this is my case is a 53-year-old non-smoking obese female with dyspnea and stridor on extubation from bariatric surgery. She was evaluated by the local ENT on call and was found to have a posterior glottic tumor and a very small glottic opening, and a tracheostomy was performed. So in her past medical history, she has diabetes, she has a history of melanoma, and notably, she had a left breast cancer that was treated with bilateral mastectomy, a left axillary lymph node dissection, and she had chemo RT to the breast, the axilla, and the low neck for some supraclavicular lymph nodes.
Do you know how long ago was that radiation to the neck?
It was 11 years prior.
11 years prior.
11 years prior.
The reason I ask, we'll talk about it later. Okay.
Yeah. And she's a never smoker, and she's a teacher. Okay. Sorry. So she was referred to my medical center and evaluated by our laryngologist. And this is her laryngoscopy. These are the laryngoscopy photos. You can see there's a posterior glottic tumor that's crossing midline. And then past the tumor, there's no obstruction. You can see the tracheostomy there.
Mm-hmm. So the tumor is posteriorly based, and I didn't see any mucosal. Is it all submucosal?
Yes. Ooh.
Okay.
Go back.
So submucosal tumor of the posterior larynx. Julie, what would you do?
Well, I think she needs a biopsy.
Yeah.
Because that's weird looking. So that'd be my next step.
So this is the type of submucosal ones are the one that I rely on MRI a lot, because I think the MRI is the superior modality here. But as Julie said, that the biopsy of these are sometimes could be tricky because you don't see a mucosal lesion. And I see Kendra just joined. Well, thanks for joining.
Yes, hi, sorry I'm late.
No worries. Okay, what's the technique of the biopsy here? Let's ask Loriano. What's your technique of biopsy? And then we'll ask Marita.
I mean, there's a couple of options. It depends on how deep into the submucosa you think you need a tumor. So, I mean, in some patients, I would consider just trying to take a piece out of it. But if you can't reach it under the mucosa, maybe open it up with a laser and then take a biopsy of what's underneath. It just depends on what it looks on the imaging. Yeah.
Okay. Any other techniques? Anybody else would like to comment, Marita? Any techniques for you when you have these submucosal tumors?
No, I agree with Lau. I think that I would want to see the imaging first, basically, because that'll help inform the biopsy.
Yeah. Okay. All right, Alice.
Okay. And then here is the imaging. Okay, I can scroll through it slowly. So you can see there's a tumor that's centered on the cricoid. There, it's spaced on the right side, but it's crossing midline. Sorry. My scrolling is slow. And here's the tumor here. And then it's kind of on the undersurface a little bit, and then the rest of the trachea appears normal.
And it looks like it is a chondrosarc, but
Yeah, exactly. There are some calcifications here you can see that are kind of characteristic of the chondrosarc. And so, I mean, for the interest of time, should we just skip to the biopsy?
sure.
Okay, sure. So she was taken to the operating room by my laryngologist, and he did an endoscopic kind of debulking as part of the biopsy. You can see the tumor here on the bottom right, and it's removed from the posterior cricoid area. And then this is her exam after the debulking, and she was decannulated at that time.
Interesting.
Yeah.
Okay, and now she's in your office.
Yes. So the pathology came back, chondrosarcoma grade 1.
Okay, well, Andrew, what would you tell this woman?
Well, it's interesting. You know, you said you had those calcifications on that, but was impressive was the inner lamina looked reasonably well preserved. You know, it wasn't bad, and certainly the posterior lamina of the cricoid was okay. And so, you know, I think these chondrosarcs as a low grade chondrosarc can be handled more expectantly with a good patient in terms of being radical. You know, you can certainly be definitive and take the larynx. The complications of resecting the posterior cricoid and reconstructing that and planning on keeping an intact larynx are you know, are incredibly difficult when you lose those PCAs. They're, you know, trach dependence, if you can save the cords. But I don't know that you couldn't do a little bit more of an aggressive endoscopic resection and debulk this thing more, trying to shell it out of there. You could kind of see that capsule of the tumor from when the laryngologist had taken that out, and get out as much gross disease as you can and follow it closely. You know, it's not going to metastasize. It's going to be a local destruction phenomenon, and what's her functional level and what she wants to do. Or if she's going to worry about it, take it out.
Yeah. Marita?
Yeah, I agree. We all know the natural history of these, and thankfully they really do well, and you can focus mostly on what you want to do for this person functionally. Quite frankly, I would try to have this be the laryngologist's problem for as long as possible until it became necessary to do more extensive surgery.
Okay, well, so let's ask Dr. Harris, what is the role of radiation in this woman? Low grade, I assume.
Yeah,
chondrosarcoma. Prior radiation to the breast. Yeah.
Well, so I guess a couple of comments. Typically, the use of chemoradiation and post-mastectomy radiotherapy suggests a triple negative phenotype. And if there were unresected infra and supraclavicular nodes, it's possible that an advanced treatment approach was taken, and the timing's actually right in line with a radiation-induced chondrosarc, potentially, if you reconstruct the fields. I think especially the way that it's centered sort of right at the inferior, just kissing the larynx, that would be a typical endpoint for the upper edge of a aggressive supraclav field. So that's one comment, that this may well be a radiation-induced malignancy. The second comment is the data for chondrosarcs in other locations, since obviously this is a very rare subsite, is that radiation, quote unquote, adjuvantly would only be indicated for non-improvable surgical margins in a place with poor salvage. If you have a reasonable expectation for an indolent course, radiation wouldn't be the chosen tool, even if you weren't overlapping with a field that probably caused this problem.
Yeah, excellent comment. Thank you so much. Okay, well, Loriano, the head and neck surgeons are calling the laryngologist. What would you do? You're mute.
At this point, I would sit on it and wait on it and see what happens with the debulking surgery. this is grade 1, low grade chondrosarcoma. So I mean, I might have not decannulated the patient after the debulking. That's the only comment, just because I would, wait maybe a couple of weeks to make sure that the airway is stable and then decannulate the patient in the clinic.
Sure.
But otherwise, in terms of treatment, I would observe it with imaging and clinic-based evaluations.
Julie?
Yeah, I agree wholeheartedly. I probably wouldn't have made the decannulation decision right then either. But yeah, I think watching and waiting, these can go a really long time with really great function and some
All right,
additional.
so
I apologize. She was decannulated a couple weeks after, but before she saw me. So when I saw
Alice-
her, she had healed. She had normal,
Yeah.
normal function, normal voice, and keep the
So the patient goes around the world and comes back to you, seems like it.
Okay.
So what did you decide?
I did exactly what Marita was suggesting. I try to make this the laryngologist's problem for as long as possible. So, this is a young patient, 53 years old. We highly recommended that we do observation, and if it recurred, to do endoscopic debulking or endoscopic debulking at the time. But this was her third cancer, and she was a single mom with a son, and she was very adamant that she have the tumor removed.
Okay.
And I talked to her about, we could start with a partial laryngectomy to see if we could get clear margins, but she was very adamant because we weren't sure we could get clear margins with a partial laryngectomy, that she wanted the total laryngectomy.
So let me ask, if you were going to do partial laryngectomy, what kind of partial laryngectomy would you consider doing?
Well, I would have considered doing a vertical partial laryngectomy. I don't have that much experience with these, but that was what my recommendation would have been, to start with a partial laryngectomy. And then if the margins were positive, or if she recurred after.
Yeah.
And even though, these are, when I think of chondrosarcoma, I first look at the grade, because grade 1 is very different from grade 3. And the grade
Sure.
3, the prognosis is poor. Grade 1, the prognosis is good. It looks like no matter what you do for the patient. However, when you do the endoscopic debulking or kind of a partial laryngectomy, there's a pretty high chance that they'll recur. But I thought, since she was young, that this would be a good option for her. But she was very adamant. We had her watch videos of laryngectomies, patients, and their speech. So she opted for the total laryngectomy.
Yeah. So, okay, this is a great point. I mean, obviously, you guys did the right thing. But so a vertical partial, and I just did one last week. You don't touch much of the cricoid. You keep it. And if you do a supracricoid, again, you're relying on the cricoid. Now, the problem here is the cricoid.
Yeah.
And not only the problem is the cricoid, it's actually posterior. Anteriorly, you can basically do a cricotracheal resection, and that's your thing. But this is a posterior problem. So how do you approach this, and how do you get to this if you're going to do that? Let's see, Andrew and Loriana, what would you guys do?
Andrew was talking about destabilizing the BCAs and not having them. I think that would be, this patient, if you try to do a partial laryngectomy going through the cricoid, would be very difficult to have a stable airway. So she'd probably be trach dependent anyways. So,
yeah.
And probably non-functional at all in terms of swallowing and voice. Swallowing would be questionable. Voice would definitely, her function would not be great. I don't know if you agree with me, but.
Andrew, if you were going to do a partial laryngectomy, how would you approach this for a posterior cricoid tumor?
Right. So, as you said, in terms of like a cricotracheal resection, you can take that anterior ring, and then even in the partial, supracricoid partial laryngectomies, the extended ones where they're taken down to tracheal ring for the anastomosis to get the subglottic extension, you still have to lead posteriorly. There really isn't a good way to do this unless you're going to leave one functioning unit. You're kind of getting to a Pearson near total laryngectomy situation if you're going to consider conservation at this point. Could you have gotten that contralateral cricoarytenoid joint and saved that like in a Pearson and near total is the only real way I think you could save that posterior lamina. I've seen some of our most talented colleagues rebuild the cricoid with some very complicated free flaps, but I've never seen anybody take all of the posterior lamina and keep any function with doing that.
I agree that, we in Toronto, we used to do a whole hemilarynx with TPF and chondral cartilage and all that. And some of them would do great. But again, posterior cricoid, I don't know. Anybody knows, Julie or Marita? Any comment on doing partial larynx, basically larynx preserving when you have to remove the chunk of a posterior cricoid?
I don't, this is Julie. I don't have an additional insight there. That's really dicey. So I think I'd be in the same boat as everybody else in terms of that. I don't know that I would go down that road in my hands.
Yeah. Marita?
Agreed. I don't have any creative ideas to share.
Mike, you're a microsurgeon. Would you do this with the thumb recon?
No, I wouldn't. I think just given the extent of posterior extension, yeah, we talked about you could rebuild half of it or the anterior part, but I would not attempt it, because even if you rebuild the structural component, as was mentioned earlier, you're detaching all the muscular attachments. You're not going to have any sort of, arytenoid function afterwards. So I don't think I would. I think you would also be much less clean oncologically, and this would be functionally and oncologically more sound to do a total.
This is I don't know which one of my mentors used to say. He said, this is not a bad tumor, but it's in a bad location. And I think, in all fair honesty, Alex, I think that was the right decision. That probably the patient was up to something.
Yeah, well, you'll see. So after I actually really just recommended the endoscopic, the follow-up and the debulking. And once she said, no, I'm getting a laryngectomy, I didn't really fight her too much on that. So she had a total laryngectomy. I did remove, because chondrosarcomas, even though they're slow growing, they can invade into the surrounding tissues. So I did remove a portion of her thyroid gland that was kind of around the cricoid on the right side, as well as a small area of the pharynx. And I reconstructed her with a supraclavicular flap, and then I placed a TEP on her. So the cricoid came back chondrosarcoma. It was invading the surrounding soft tissues. All the margins were clear. The larynx and subglottic tissues actually had squamous cell carcinoma in situ, involving both vocal cords and bilateral subglottic area. And her thyroid gland had a multifocal papillary carcinoma, microscopic type. And I had removed some lymph nodes that were in the area as well. And 2 out of the 6 lymph nodes had metastatic thyroid cancer.
Yeah,
So
that
Alice,
has happened to me.
I put a comment in the chat. I mean, a patient who has a bilateral mastectomy for prior breast cancer with a sarcoma, whether or not it's infield or not, and a presentation of a thyroid cancer would be a strong indication for a genetic medicine evaluation for heritable risk.
Yes.
Syndrome.
She underwent genetic evaluation before surgery, and they didn't find any identifiable mutations. Yeah.
Okay. So what would you do now?
Okay. So I'm sorry. So for me, should I keep going?
Yeah, go
ahead. We had her evaluated for endocrinology, but we did want her to get radioactive iodine. So you can see here, this is her CT scan after surgery. You can see the supraclavicular flap. And I was going to comment on the last case that Riz presented, that I almost never do free flaps anymore for total laryngectomy with partial pharyngectomy, because I think the supraclavicular flap is so reliable and so low morbidity. But for total laryngopharyngectomy, I do a free flap, a tubed free flap. Mm-hmm. And this is here. She's got a nice flap, great swallowing, and you can see her residual thyroid on both sides of her flap. So I did wait 3 months to kind of let her flap have some more time to integrate. And then I took her back for a completion total thyroidectomy and central neck dissection. And then she had radioactive iodine after.
Interesting.
Yeah.
Wow.
Yeah.
Okay.
Say it,
went
but
for chondrosarc and came up with another cancer.
Yeah. So that would be 5 cancers for her. Yeah.
I was going to say that.
So we did, Kendra, you mentioned the radiation-induced sarcoma. So we didn't do her radiation 11 years prior, but we did get her radiation records, and they did give a considerable dose to the cricoid area. It was within the field. So this probably, all of these 3 last cancers were probably radiation-induced.
Well,
Did you do germline genetics? Is that the genetic eval she underwent?
I'm not sure. I have to look, but we did send her to genetics.
Well, to Kendra's defense, I don't think squame is radiation related. The inside to a squame is not the radiation fault.
Yeah, it's
Papillary
unclear though.
thyroid, yeah.
Yeah, but she's never smoked.
Yeah.
So I'm not completely sure. but-
Wow, what a fantastic case. It's okay. If there are no last comments, it's 8:04. I cannot thank you enough for the fantastic cases and excellent conversation and discussion. I definitely learned quite a bit. For those of you who follow us, we have our next session, March 31st. It would be our first joint session with the skull-based section, and it's an international panel. It will be at 6 o'clock Eastern time on the skull-based tumors, so I hope you can join us. Thank you all from New York City. Thank you to all the presenters, Dr. Aslam, Dr. Lin, and Dr. McWhorter, and our fantastic panels, Dr. Tang, Loriano, and Kendra, also came late, and also Julie. It was a phenomenal tumor board. Thank you. I hope we have you for the next sessions. Have a great evening.
Thank you, everyone.
Good night, everyone. Thank you.
Nice meeting you.
Thanks, everybody.
Thanks, everybody.